We're going to just give people just a couple seconds to start piling in here, and then I'll get us started. All right, so I think we're pretty much right at the hour. So I'm going to go ahead and just get us started so we don't waste any time, because we want to make sure that you have as much time as you can possibly have, because we're looking forward to the content. So welcome everybody to the University of New Mexico Law and Mental Health Didactic Series. This series is hosted by UNM, Department of Psychiatry and Behavioral Sciences, as well as the New Mexico Behavioral Health Services Division. We're so glad to have you all joining us today. My name is Simone Fouillon. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. I just want to put our usual plug out for next week. We have Dr. Joel Duboskin, who's going to be presenting on creating a criminal justice system that prevents violent crime. So that should be really good. I hope that you all can join us for that next week. For our talk today, as usual, please put your questions in the Q&A app or thingy whenever you feel comfortable, but just know that we're going to do the questions at the end of the presentation. Our presenter today has said that she can stay on for about 5 minutes afterwards, so we're going to be kind of keeping it to a little bit more of a tight timeline today. So having said that, if we don't get to your question, we apologize in advance. We do the best we can to get to everybody. For those of you that are on a tight schedule too and really can't stay even 5 minutes beyond, that's fine. Just make sure you grab that CE link, which will be posted right about 5 minutes before the hour. Remember to download or save or screenshot whatever you need to do the actual certificate once you've completed the survey, because we don't have any way of retrieving those or obtaining those for you. So you have to make sure that you save those yourself. For those of you that need CMEs, so for those of you that want to get medical credit, the sign-in should be in the chat right now. So you can go to the chat and sign in for that. That's just for folks that need CMEs. The CE link gets posted in the last 5 minutes, like I said. We are going to be sending out the recording to everybody, and the presenters asked us to hold off on the PowerPoints because we need to kind of check on a few things. So we might not send the PowerPoints out just yet, but we will be sending the recording link to everybody. Okay, so now that we've done all the housekeeping things, I want to get to what we are all here for. I want to introduce our speaker today, Dr. Jhilam Biswas. Dr. Biswas is a board-certified adult and forensic psychiatrist and is the director of Psychiatry Law and Society program at Brigham and Women's Hospital in Boston, Massachusetts, and the co-director of Harvard Mass General Brigham Forensic Psychiatry Fellowship. She's also an attending at the Psychiatry Consult Liaison Service at Brigham and Women's Hospital. Dr. Biswas specializes in mental health consultation to the legal system and focuses on nuances of both criminal and civil law. Since starting her practice, she chairs and serves on multiple psychiatric, forensic, and medical committees, statewide and nationally. Currently, Dr. Biswas' research aims at improving mental health laws to better serve patients and families. Her expertise is in serious mental illness, risk assessment, violence prevention, cultural competence, and consulting to social institutions and organizations. Hopefully I didn't sound too much like an auctioneer. I try to do it as fast as I can without sounding too fast. But Dr. Biswas, on behalf of UNM, welcome. Thank you so much for sharing your time with us. We really appreciate you being here today, and I'm going to turn it over to you.
Thank you so much, Simone. I really appreciate that introduction. And hi, everybody. It's nice to be able to present some of this to you. It's sort of something that is new. And this stance that the World Health Organization is taking and evolving is their newest document is from 2021. So I feel like this is kind of cutting edge, and we're going to be talking about it and thinking about it and seeing how it will make sense in our societies moving forward. So the title is the World Health Organization Stance on Eradicating Treatment Over Objection. We're going to do a risk-benefit analysis and think about the future. So thank you so much for having me. And the objectives of this talk will first be understanding WHO's stance on involuntary psychiatric treatment of individuals with serious mental illness. consider the research and case law behind the right to refuse treatment and the right to treatment in the seriously mentally ill. I think it's important for us to see what we've been doing in the United States around this issue, and then learn about some of the consequences of untreated serious mental illness and consider possible solutions that we can implement in the United States, and maybe add to the discourse that's happening globally. So let's talk a little bit about this comprehensive mental health action plan. This first came out in May of 2013. So the World Health Organization has been active in acknowledging mental health as a large global burden of disease and is doing its part to support solutions around various action plans. And so I think it was in 2013, the 66th World Health Assembly, consisting of the ministers of health from 194 member states, adopted the WHO's Comprehensive Mental Health Care Action Plan in May of 2019. This was the same time, actually, that the DSM-5 came out in the United States. So in 2019, this action plan, so we're fast forwarding about 7 years, we've kind of gone through what the core objectives of this mental health action plan are. And in 2019, they actually extended it to 2030. And that was done in the 72nd World Health Assembly. And then again, 2 years later in 2021, the 74th World Health Assembly endorsed updates to this action plan, including updates to the plan's options for implementation and indicators. And out of that update came in 2021 a guidance, a WHO guidance on community mental health services. So this updated comprehensive mental health action plan from 2013 to 2030 builds upon its predecessors and sets out clear action for member states to promote mental health for all and to prevent mental health conditions for those at risk and to achieve universal coverage for mental health services. And while this updated action plan includes new and updated indicators for implementation, these original core 4 objectives remain unchanged. And I'll tell you what those were from 2013. And those core objectives are more effective leadership and governance for mental health, the provision of comprehensive integrated mental health and social care services in community-based settings, implementation of strategies for promotion and prevention, and strengthened information systems, evidence, and research around mental health. As we all know, the global burden of disease, I think depression and serious mental illnesses like bipolar disorder and schizophrenia, these combined are the biggest global burden of disease in the world. I think it's just under cardiovascular disease. And so it has huge costs to disability and mortality around the world. And these world organizations are taking notice. However, it's going to be important to voice, suggestions to these groups as they make these decisions, because in the United States, we've sort of lived through a lot of different policymaking in mental health, and we've seen some of what works, some of what doesn't work, and areas that are somewhat broken in our system. And so it'll be important for the United States to have a voice. So let's talk a little bit about the 2021 guidance on community mental health services that came out. So it recently published it. It emphasizes mental health care must remain the focus of the focus must be the preservation of human rights. And from a global perspective, that certainly makes sense. And to do so, it recommends transitioning away from hospital-based care, prioritizing a holistic treatment model over medication management, facilitating the development of community-based programming and social supports, and creating legal frameworks to remove treatment over objection is kind of the area we're going to talk about here, because that's been some of my research and my team's research on looking at kind of what happens in situations when people are acutely mentally ill and we don't really have the services or resources to be able to manage a crisis. So the major goals of this 2021 guidance is highlight mental health systems that are focused on rights-based recovery process for individuals with mental health needs, reinforce political commitment over decades to adopt recovery-based approach to care, integrate many stakeholders around society to work together, which 100% is a really important thing, because the mentally ill population really touches all aspects of our social institutions, and yet we tend to work in silos and we don't always talk to each other. I know that my audience today is forensics, and we sort of have that bridging ability where we're kind of looking at these various social institutions, and perhaps it is some of our work to start educating people about what mental illness can really look like, and get these stakeholders involved, and remove institutionalized mental health care, inpatient hospitals, and bring care into the community. Okay, great. These are somewhat good goals to aspire to, but what do we do when someone has anosognosia and is really sick and won't engage? So I think all of us possibly in this group have dealt with acute situations where we can't really get people to agree to treatment, and they're really sick and vulnerable, and unfortunately, because of that mental illness, are displaying dangerous behaviors, either to themselves, to others, or just unable to take care of themselves. So we have to think about that population. And so what I want to talk about first is, how do we do this education around anosognosia? So we know people with acute mental illness, often with psychotic episodes or manic episodes, well, 50 or higher percentage of those individuals are experiencing anosognosia. And anosognosia is, brain imaging studies show that crucial areas of the brain's frontal lobe are affected in schizophrenia and bipolar disorder and certain types of dementia. And that sort of areas of the brain that are impacted can result in misconceptions of self-image and result in a lack of insight. So self-image, self-awareness, that kind of results in a lack of insight. That is a symptom that we see often in mental illness. And it is actually the single largest reason for treatment non-adherence in the seriously mentally ill. And so this is a piece that if we don't address, along with building in community health services and trying to remove inpatient hospitals from the conversation, we're really going to have to think about those periods of time where people are just not taking their medications and not doing well in the community. And again, just a little more information and education on anosognosia. It was a term that was first used in 1914 by French neurologist Joseph Babinski to describe the lack of awareness and insight into one's disorder. Now, actually, there are papers from the 1800s talking about anosognosia, not necessarily calling it that, but recognizing there is this lack of insight that occurs with mental illness and certain dementias and strokes. And it's just sort of the way our brain can work in these disordered states. But the credit is given to Joseph Babinski in 1914 around this symptom. And like I said, many cognitive disorders manifest this symptom. And this is a common symptom of psychotic and manic illness. So what has happened? So I'm kind of like taking little pieces of this argument to help weave together what we've learned over the past 60 years around anosognosia, around deinstitutionalization in the United States, and how to actually build in community health supports. So, okay, we have this problem of anosognosia that exists in a small subset and sometimes large subset of the seriously mentally ill when they're acutely ill. And at the same time, we have this process that happened in the United States of deinstitutionalization. And basically, we had a lot of state hospitals across all 50 states that took care of the mentally ill up until the 1950s, 60s, and 70s. That whole process was started originally by Dorothea Dix advocating across Massachusetts, which is where I'm speaking to you from, and then across the country, and Elizabeth Packard in Illinois, who was also doing a lot of advocacy in the 1850s to bring in all these state hospitals and institutions, because the asylums at that time were doing a terrible job of taking care of the mentally ill, and they felt like there needs to be a specific space in large, natural areas. We need to have hospitals where we really take care of the mentally ill. So that's how it all started in the 1800s, 1850s, all the way to the 1950s. In the 1950s, we had a lot of state hospitals, thousands and thousands of beds across the country. In 1955, we discovered the first antipsychotic drug, Thorazine, which was seen to be actually useful for quelling positive symptoms of schizophrenia. And there were a lot of people who took Thorazine and actually started to do better. At the same time, there were a lot of moving, swirling aspects in American history that started reducing the number of beds that we see currently today. So Thorazine was the first step where we finally had a type of treatment for schizophrenia and particularly acute psychotic illnesses. And then in 1965, Medicaid and Medicare was enacted, and these were federal benefits in order to pay for treatment. So the state said, well, we don't want to pay for all this mental health care treatment. Let the federal government do that. So the states all started shutting down their hospital beds. And then in the 1960s, there was a huge civil rights movement, and John F. Kennedy was president at the time, and he had family members who had mental illness. He was very interested in building in community mental health care, and he had the Community Mental Health Care Act enacted during his presidency. And so that was the goal, is let's deinstitutionalize people who have serious mental illness. Let's bring them out into the community. Let's get community health services, and let's have the federal government pay for it. Well, as we all know, that did not work out very well. The problem was we were decreasing all of the state beds throughout the process, where we were not able to get really strong community mental health care systems into place. Some local systems were doing well, but many did not have any funding to really build in proper community mental health care. So what happened was then the Reagan administration came after the Carter administration, and then kind of pulled away a lot of the funding for community mental health services. And so what happened was we were reducing all the state beds. We didn't have the proper community mental health systems in place, and people were left on the streets. They were not necessarily taking their medications, not necessarily staying in treatment, and then ending up kind of in what we see in this cartoon here. In the 1970s, we were thinking out of the box, no more warehousing, no more treatment, just freedom. And then kind of what we're seeing in the 2000s, which is living inside the box. And we see a lot of homelessness and incarceration, which is really a true human rights violation, where we are now incarcerating the mentally ill at levels that we've never seen before. And so, the first piece of this is community mental health services do have to be supported in order to address acute issues, but also that we can't just eradicate medications from the picture of serious mental illness. We can't. We just, that's part and parcel of the treatment. And it seems kind of at the global level, there's sort of missing understanding that that is a really important piece. So here's just some books that came out from the 60s onward of all of us realizing what deinstitutionalization did, kind of within the context of a lack of community health services, but also within the lack of understanding that treatment refusal can also play a role. So we see the victimization of the mentally ill, the criminalization of the mentally ill, and sort of this uprising in homelessness from asylum to prison. Homelessness and then asylum to prison. And this is a great book by Pete Earley, who's a Washington Post reporter who wrote this amazing book about the father's search through America's mental health care madness, and seeing his son, who suffers from schizophrenia, kind of bouncing between homelessness and prison, and not being able to get treatment for his son, because it is often very difficult given kind of this, the laws that we have. So that's the next piece we're going to talk about. So we talked about, okay, so we have this overriding issue of, anosognosia as a part of serious mental illness that exists and often creates this sort of non-adherence to medication. Then we have this whole process of deinstitutionalization with no real safety net, and sort of homelessness and incarceration is the choice. And then sort of there's this other piece that happened in the United States that we'll talk about, which is the case law that occurred around treatment, the right to treatment of the mentally ill and the right to refuse treatment in individuals who have anosognosia. So let's talk about the case law. So the models for treatment refusal, what do we do when an individual is mentally ill and dangerous because of their mental illness, from self-harm, harm to others, or just being gravely disabled? So we have a whole slew of case law that exists across the country that deals with this issue state by state. And there are some, there's a whole set of states that kind of adhere to one way perspective, and then there are other states that adhere to a different perspective. And it kind of goes across the spectrum from treatment focused case law to rights focused case law. And so let me say a little bit about the laws. All right, let me show you. Okay, so we've got the treatment driven models. And that's the New Jersey model we'll talk about. And then we've got the rights-driven models, which is the Massachusetts models. And these laws, okay, the whole reason that these laws exist regulate the implementation of involuntary psychiatric treatment. And they've historically been justified on two principles. So one is the protection of the public, and two is the protection of the mentally ill individual from imminent harm. So this is called parens patriae powers of the state, give certain authorities the right to provide treatment against an individual's will, with recent movement to calling this nomenclature from involuntary to assisted treatment. We talk about this as assisted treatment because ultimately what you're doing is you're not treating someone against their will. You are dealing with the symptom of serious mental illness, which is anosognosia, which is this sort of inability to even process the fact that they're mentally ill. And you're addressing that piece of it so that all of the rest of the recovery can happen. And so that is the word assisted is a better reflection that these interventions are meant to benefit these individuals with impaired ability to make decisions on their own. And while the legal standard of least restrictive means has long been cited as the core principle of this intervention, sometimes, the reality of this is there are resource limitations, and there are varied local and state legislation that kind of look at these differently. So let's talk about that. Okay, so here is the model, treatment-driven model, the New Jersey model, that kind of really looks at professional judgment when it comes to treating someone with serious mental illness in an acute psychotic episode. So in that model, the physicians make treatment decisions. There is no judge needed, and the priority is really timely treatment. And you're looking at beneficence over autonomy. The rights-driven model, which is the Massachusetts model, it's what I live with as a psychiatrist in my state, and what we actually did a research study on, which I'll talk about in the next segment. The judge makes the treatment decision. You have to go through an adversarial process, an adversarial hearing. You have to wait for the hearing to take place. The judge makes the treatment decision, and this prioritizes the patient's right at the time that they are mentally ill. And it looks at the autonomy of the patient at that moment in time versus more than the beneficence. Okay. And so here is some of the case law that we'll discuss. So the Rennie v. Klein case law is what determined the New Jersey model. We'll look at Washington v. Harper. There's also a Utah state-based case law that's similar to this. Washington v. Harper is more for federal prisoners and individuals in that setting, but there are state laws that follow the Washington v. Harper model, and there are panels of decision makers that come together to make the decision for treatment over objection. And then we have Rogers v. Commissioner, which is the case law in Massachusetts for substituted judgment, adversarial hearings, and basically spending a lot of time to decide whether that treatment should be given to that psychotic or manic individual. I would say like 90% of the time, that's kind of what we're dealing with when we're dealing with the Rogers. Okay. So the Rennie v. Klein case law. So we're going to do it from a question form. This comes from this incredible book, if any of you are interested, Landmark Cases in Forensic Psychiatry, to just sort of, talk about the core question. So in New Jersey, do civilly committed individuals have the right to refuse antipsychotic medication? The answer is yes, but. So let me tell you a little bit. This was John Rennie. This was during his 12th hospitalization, and he initiated a suit claiming he had constitutional rights to refuse antipsychotic treatment. And actually the district court did agree with him, and the U.S. Court of Appeals appealed it in the 3rd district, and they found that this constitutional right to refuse treatment did exist, but also found that the administrative procedures outlined in the New Jersey Administrative Bulletin, and this is like a document which requires an administrative review board in the hospital to make the decision around treatment, provided adequate protection and satisfied due process. So New Jersey found that the hospital's policies do satisfy due process. This case went to the Supreme Court, which then also was, this was 1982, it was looking at Youngberg v. Romeo, which is another case that was going through the courts at the same time all of this case law was going through in the 1980s. And there they found that the professional judgment did stand. And so the Supreme Court adopted the standard of professional judgment and said that this should be added to the Rennie v. Klein case. And so, so that was sort of like the emblem of a professional judgment case where the doctors and other team members come together, look at the case and say, look, this person needs treatment. We can give this over objection in order to allow this patient to recover quickly. Okay. So that is this case. And then we've got the Washington v. Harper case. The question here, the crux of the question here is a judicial hearing about medication required to satisfy due process for a dangerous convicted prisoner refusing psychiatric medication? The answer is no. A judicial hearing is not required. Walter Harper was incarcerated in Washington state penal system, refused to take antipsychotic medications, and the Supreme Court, this case went up to the Supreme Court, they decided the following. There is a legitimate state interest in combating danger posed by a violently mentally ill inmate, and there is little dispute that the proper use of antipsychotic medication is an effective means of treating mental illness. So this is what the Supreme Court held. They believe that there is little dispute that proper use of antipsychotic medications is effective in treating mental illness. That, unfortunately, was not the case in Rogers v. Commissioner, where the Supreme Court was saying one thing, and then sort of Massachusetts went in a very different direction, and the case law still stands. So in Massachusetts, what is the case law? The case law is, in Massachusetts, can an involuntary committed patient, someone who's already committed to the hospital, seen as mentally ill and dangerous, can they refuse psychiatric medication? And the answer is yes. So there was a class action lawsuit against the Department of Mental Health by Ruby Rogers and a group of patients challenging medicating patients against their will. So this case actually went up to the Supreme Court as well, where it was vacated and sent back down through the courts and back to the district court to explain themselves so the court could give some guidance. So this was confusing to the Supreme Court and all the other courts because they were like, well, we're kind of going in this other direction with these other cases, and this is it may be kind of in context to your state, but this is not what other states are deciding. And so the case ended up getting approved in district court. And the decision there was antipsychotics alone cannot be authorized by a legal guardian. So even if you have a medical guardian for someone, there needs to be a separate guardian ad litem to determine if antipsychotics should, when they should be used. And in the hearing, only a judge can be the substituted decision maker to determine the need for medication. So a doctor can't do that. It needs to be a judge who has to put himself in the shoes of the patient and decide whether medications should be used. And the doctor must testify in court, and the hearing cannot be waived if the patient agrees to medication. You still need to have this adversarial hearing. Some of that we're seeing changes in right now in some of our state hospitals, but for the most part, you can't waive a Rogers hearing because the judge is assuming that the patient is incompetent and is going to have to use substituted judgment, and so the hearing can't be waived. Okay, so So we have this case law here in Massachusetts. And again, let me just remind you why we're talking about this case law, because at the highest international level, we're moving towards the space of eradicating hospital care, really thinking about doing this from a community perspective, really maybe removing medications from consent. And, that's kind of at the hierarchical level, like that's the direction society wants to move in. But what are we learning from the data, and what do we need to assimilate in order to properly have that vision play out? And so I'm showing you that the case law and the history in the United States of like what we've learned, what we know, what we need to change, and how that may or may not fit with this kind of overarching vision that we're hearing from the WHO. So here is some of the research that we did at the state hospital that I worked at for many years, Bridgewater State Hospital. What do we know from the Rogers case law? So our study setting was this hospital. It's a forensic hospital and a medium security prison run by the Department of Corrections. It's a strict security setting where we have only male inmates. Those individuals are often charged, not necessarily convicted, but charged with a violent charge. And it is owned by the Department of Corrections, but the clinical work is done by a contracted vendor that hires all of the clinical staff. So that's kind of where we looked at how the Rogers law plays out. What does it look like when we can't really, when we're using adversarial hearings to get treatment to individuals with mental illness? Okay, so what we looked at was the Bridgewater patients and the Rogers petitions, that's what we call them in Massachusetts. We looked at all of the petitions the doctors had to file to the courts in 2015 and 2016. And that was a total of 355 petitions that we filed to the court. This was first commitments to the hospital and recommitments. Okay. And what we looked at, the process, 8B is another word for Rogers, so I can talk about that more clearly. But at admission, by statute, we have 20 days to 30 days to do a forensic evaluation on that individual. So during that period of time, if that person is refusing treatment, you can't really get standing treatment, antipsychotic treatment to that individual. So then we've got the 20 days. And then once the doctor files the petition, it takes 14 days to get on the court docket. Then once it's on the court docket, it is in this adversarial judicial process. So there's an attorney on two sides of the case, the hospital attorney, and then the public, often the public counsel that is assigned to the patient. And then there's sort of this period of time that goes by with continuances. Maybe there's a need for independent medical examiners. And we looked at that. I'm not going to talk about it here in this session, but there are a lot of reasons why these cases can get continued. There's administrative purposes and all of that. So these cases can get continued. And then finally, we'll get the petition allowed to treat the individual over objection. And then we looked at the period, the 3 months after that period of time to see, was there improvement? And then that's the end of the observation period. So here we are. So we're looking at, are there these adverse events that occur with individuals who are dealing with serious mental illness before we can get treatment in place and after we can get treatment in place? And you can imagine some of this is, it's clear, but unfortunately, this is what the laws make it what the laws force us to do, is kind of sit in this waiting period of time where someone is acutely mentally ill, but we can't treat them. Okay. So, so what are the adverse events that we looked at for somebody who has serious mental illness? We looked at self-harm, suicidal, and psychotic incidents. And the way we looked at this was we reviewed every single incident report that was written up by clinical and correctional officers on these individuals during that period of time from 2015 through 2016. We looked at every single incident report to see what were the incidents that occurred during the period of time that person was not treated and during the time the person was treated. So we looked at self-harm, suicidal and psychotic incidents, aggressor violent incidents where the individual was an aggressor. We looked at violent incidents where the individual was not the aggressor. We looked at patient aggression towards staff members, and we looked at climate incidences, and those were, acting in a manner that was disruptive to other patients, shouting threats in the milieu, acting inappropriately, property destruction in which the other person was not harmed, personal hygiene that disrupts others, and refusing to comply with staff instructions. And so those were the climate incidents that we were looking at throughout. Okay. Okay, so the population we looked at was 43.9% Caucasian. The Massachusetts population is 80% Caucasian. African-American population was 35%, but 9% in Massachusetts, but 35% within the hospital. The Hispanic population was about 16.9% of the represented subjects. The actual percentage is 12% in Massachusetts. And then the Asian population was 2.5%. The actual population in Massachusetts, 7.2%. And so there's clearly a skewing of minority populations in a forensic hospital that you can see from the demographic data. We also saw that the average age range was, we're looking at a lot of first episode psychotic illnesses. So by and large, our population was between the age of 25 and 34, and the gender was all male in this group. Okay, so what did we see in terms of the results? So in terms of treatment delays and why this is important. So this is the period of time where someone is acutely mentally ill and not receiving standing antipsychotic treatment for that mental illness. Okay, so we saw that amongst the patients where the treatment petitions were accepted, recommitted patients experienced significantly longer delays. So these are individuals who already have a treatment plan in place and it expires after a year. And so they had a delay of 44 days, and the mean was 41 days of delay. So this is after the 20 to 30 days of forensic evaluation. Then there's the 14 days of getting on the docket. And then we have an average of 41 days due to waiting for an adversarial hearing to get treatment to this individual. So that's what we're seeing there. And what the hearing outcomes showed was, let me just explain this to you. Accepted hearings were where the judge agreed with the doctor that this individual needs treatment. 16% were actually withdrawn by the psychiatrist or nurse practitioner even before it got to court. So those are situations where the patient either eventually, from waiting for treatment, eventually agrees voluntarily, or there's for some reason they're able to get that patient on treatment without actually getting to the hearing. That was 16.3% of the time. Then that's when the doctor withdraws the petition. And then in the cases that it was denied was 0.8%. So 99.2% of the time, after waiting for these adversarial hearings to happen to talk about treatment over objection, the judge and the doctor agrees 99.2% of the time. There were 3 cases representing 2 patients where the judge denied the treatment petition plan, and both of those were refiled within a week or 2 weeks after that denial, and then it was subsequently accepted. So that means actually 100% of every single petition where we needed treatment for that patient ended up getting accepted. So that whole waiting period really wasn't for anything. Okay, So another key thing that I want to talk about here, and this relates to what we're talking about at kind of the international level. So what were the results? The rate of adverse events that were reduced after the treatment petitions were allowed. Okay, so basically what we saw is there was a significant reduction in every single category of adverse event once that treatment petition was allowed by the courts. So we saw a reduction, a significant reduction in self-harm, suicidal behavior, psychotic incidents, aggressive violent incidents, non-aggressive violent incidents, and climate issues and staff assaults. We saw less of all of that once that treatment petition was put in place. Okay. So what was the summary of the research that we did? We saw that the treatment delay was about 41 days after the initial 34 days of waiting in a forensic hospital. This is consistent with previous studies done on Rogers in Massachusetts. Psychiatrist's petition for involuntary treatment was upheld by the judge 99.2% of the cases. So the judge and the doctor end up agreeing. This was also consistent across studies that were done in the 1980s and 90s on the same issue. Reasons for delay were poorly defined by the courts because there were just so many different reasons they would continue a case. All types of adverse events studied decreased after the petition acceptance. Race, diagnosis, age, and recommitment status were significant predictors of adverse events. We did find that some minority populations had a higher rate of adverse events that was the Hispanic population compared to the Caucasian population, but the African-American population and the Caucasian population were equal in prediction of adverse events, as well as older age indicated less adverse events, that they would be less violent. And we know that from a lot of our risk assessment studies. And then we found diagnosis actually was a significant predictor of adverse events when untreated. And that was if there was a mood disorder concomitant with the psychotic disorder, that was a higher indication that there would be adverse events. We actually did find that that length of delay did not necessarily predict adverse events. And the reason why we thought that might be the case is because there were a lot of patients in the population that were recommits who were already there and stable from treatment, but their treatment petition had expired. And so that's why they were also included in the study. Okay. So what do we know from the literature? So as we were doing this study, we really wanted to look at the full literature of what it means to not, what happens when there isn't medication management in someone who's having a serious acute episode of mental illness. So what we know from the literature is the effects of untreated illness, and it also showed in our study as well, that there's a poorer overall prognosis in the future. There are higher suicide rates in this population. There's higher risk of violence, increased severity of cognitive defect and decline, poorer response to medication in the future. We also know this, people who are sitting who are unfortunately stuck in a distressing psychotic state and are not being treated are less likely to recover well in the future if they do not receive the treatment in a timely manner. And we also know that these individuals who do not receive treatment in a timely manner will also have frequent relapses into illness. So unfortunately, what's happening is these patients are becoming sicker by waiting for these adversarial hearings to determine whether they need treatment or not. So what do we know about getting treatment in place in a timely manner? We know that there's a reduction in the severity of illness. We know there's a reduction in the chronicity of illness. We know it's protective against suicide attempts and violence. There's less relapse into mental illness and increased awareness and improved judgments. And the one thing we also know is there are increased side effects from medications for individuals who are on treatment. But what we also know is there's a lot of side effects to not being on treatment. So let me talk about a group that's doing the exact opposite of the WHO. And if we were to look at that rights versus treatment spectrum that I showed you earlier on the case law, well, organizations kind of also fall on the spectrum. And if the WHO falls on the rights-based spectrum of this conversation, then the Treatment Advocacy Center in Washington, D.C. falls on the treatment-based space. of the spectrum. So the Treatment Advocacy Center is a national nonprofit organization dedicated to eliminating barriers to the timely and effective treatment of severe mental illness. And this organization promotes laws, policies, and practices for the delivery of psychiatric care and supports the development of innovative treatments for and research into the causes of severe and persistent psychiatric illness, such as schizophrenia and bipolar disorder, like we talked about. So they also send out all these reports on ways treatment is a necessary part of caring and supporting the mentally ill. They've done a lot of research to show that we need medication management as a piece of recovery from mental illness. And this is this piece is completely forgotten in the WHO guidance on community mental health care. If you look at that document, it doesn't address this acute aspect that we need to deal with in order to provide stabilization and recovery to happen in the community. What's great about the Treatment Advocacy Center is it recognizes that state by state, we all look at this issue differently and we manage it differently depending on our case law. And it compares and grades civil commitment and outpatient commitment laws state by state. And actually, I have New Mexico's commitment laws, and the Treatment Advocacy Center says, they're very harsh on basically every state, and most states get Fs in kind of every area that they evaluate, because our inpatient commitment laws are not often used properly in a lot of different states, and outpatient commitment laws also are not used properly. But New Mexico actually does have pretty good assisted outpatient treatment laws. It's just, are they being put into place in a way that they are used well? That's the area that Treatment Advocacy Center is looking at. But your assisted outpatient treatment laws are very good. In Massachusetts, we're one of 3 states that do not have assisted outpatient treatment. And so we're stuck in a kind of between a rock and a hard place where we don't have any way to get treatment to people, assisted treatment to people in the outpatient setting. And then we had this sort of adversarial process in the inpatient setting. So it kind of causes this major gap that we need to address. But I think that definitely check out this organization if this is interesting to you, because they really look at this issue and do a lot of education around the fact that we need to destigmatize the treatments for mental illness if we are going to destigmatize mental illness itself. We can't allow for both of those stigmas to exist because they sort of counteract each other. And so if we were to, again, look at the spectrum of the way different organizations fall on treatment versus rights, NAMI at a national level stance on involuntary treatment is much like what the Treatment Advocacy Center says. And so their stance is involuntary commitment and involuntary treatment decisions must be made expeditiously and simultaneously in a single hearing so that individuals can receive treatment in a timely manner. As you see, what we're doing in Massachusetts, and hence the research that we're looking at, is we're not quite doing that. We're not doing it in a timely manner. And the role of the courts should be limited to review to ensure that procedures used in making these determinations comply with individual rights and due process requirements. The role of the court does not include making medical decisions. So that is NAMI's stance on this issue. And so one of the things, as we kind of put all of this together, I know I sort of threw a lot of case law and history at you. Let me just say kind of what we need to think about as a whole, as globally we're moving towards this direction of recovery-focused, community-based mental health care. If we're going to move in that direction, which is, ideal, and certainly the stance globally that we need to take in order for countries that have a lot of oppressive laws to change, what we also need to think about is there a real freedom and autonomy for those who are suffering from acute symptoms of mental illness and they don't receive treatment because they're not really able to have that decision-making process in place? And is it fair to delay treatment for those individuals? Because we know that by delaying treatment, often there is a slower recovery, a recovery to a lesser degree, and an inability to really move back to a fully functional state. And so that is a really, problematic piece that we need to sit with. And if there is this focus towards a less treatment-based and more community-based mental health recovery approach, there should be education around what mental illness can look like in a crisis. What we need to talk more about is the fact that there are symptoms of anosognosia that exist in the mentally ill, and that is the biggest reason people come off their medications. Side effects certainly are another, and we need to do more research on what are the best modes of care, and combine that research and really do some evidence-based work in forensic settings and in civil settings around this issue. But we do need to think about what an anosognosia means and how it can really impact and sabotage community-based care. You can't get rid of medication management and expect community-based care. You have to kind of have both. And so rather than stigmatizing this need, we need to empower people to create maybe advanced directives and surrogate decision makers who can kind of quickly sweep in these moments of difficulty with decision making. And if we're not thoughtful about mental health care policy around the world, as you know, we're kind of living in a very changing world right now, things are in flux. We really need to be clear that there is a tragic cycle of homelessness and incarceration of the mentally ill that comes with not being able to treat them in a timely manner and getting them the access to care. Mental health care access means medication management in a timely manner. And if we remove our ability to be able to treat in these very acute periods of time, there is greater loss. And so I just want to leave that with you, and to recognize that the stigma of treatment comes from a lot of cultural based understandings. One flew over the cuckoo's nest. That was not that was culturally something that really stigmatized mental health treatments that have benefited countless people and from life-threatening illness. And so we do really need to think about how we think about medications, that they can be useful in settings, in many settings, to allow people to actually recover in the community. And if we're going to have all of these right legal hurdles to get treatment, we're actually unfortunately taking that individual's autonomy away by keeping them locked in a setting waiting for these adversarial hearings to happen. And so with that, I know I've given you a lot, but I've left some time for questions, and I appreciate your attention. So thank you.
Thank you so much. All right, so we do have some questions. Let's get going on those. So the first question says, you mentioned diagnosis, treatment, and classifications of the mentally ill, DSM, and the World Health Organizations. So what do you think of the validity and application of the new ICD?
Of the new ICD, maybe we can, what are they referring to in the ICD that?
Maybe that person can clarify their question.
That'd be great. That'd be great, because it's a great question. Yeah.
Okay, so the next question says that in prison mental health, we certainly saw an increase, 3 times increase in business during the early 2000s. Not treating the severely mentally ill population negatively affects the environment for all. Where is the best line to draw? Here, we are most often choosing harm to self or others as the trigger.
That's such a great question. And I think that, yes, I think in the United States, we have said, okay, when this person becomes dangerous, and we've defined dangerousness across case law, across almost all states, to be, harm to self, harm to others, or being so gravely disabled that we are harmful to ourselves and others, because we just can't take care of ourselves, and things we're walking around in -5 degrees with sandals. That's being very, very sick. And certainly the prison population swelled in the early 2000s because of just not having anywhere to keep individuals who are chronically mentally ill and off medications and end up in these situations that are dangerous. And where is the line? I think the line is really looking at, can we build in, can we have a conversation that is not so polarized? We can say that there is a group of people that need extra help, that need a little more monitoring to stay on treatment so that they are not dangerous, and to work on this cycle of recidivism through, there are courts that are doing that are mandating outpatient assisted treatment, and then having probation officers maybe follow that individual. There can be some GPS monitoring of really dangerous individuals who really stay off treatment. I think this conversation just needs to start happening everywhere about how do we do this better, because there is a human rights violation on both ends. There can be a human, even if the WHO is saying there's a human rights violation in incarcerating the mentally ill, well, there's also a human rights violation in not being able to give them timely treatment, during a time that they're in acute crisis, end up doing something dangerous and end up in prison. So we're now incarcerating the mentally ill instead of institutionalizing the mentally ill. Where is the line there? What is the human rights question really at hand? We need to have a nuanced conversation that different subsets of the mentally ill need different things. The person who is depressed, anxious, with OCD is not the same patient as somebody who is in and out of jail because they're off their medication and they have a schizoaffective disorder and a personality disorder, and they're in dangerous situations. They're just different, and I think sometimes we're conflating all of the groups as one, and they're not one group. And so that's where the line is. The line is in many spaces, and we need to have a more nuanced conversation.
So the individual for the previous question elaborated a little bit. So they're asking, I guess, what your opinion of the validity and application of the ICD as compared to, say, the DSM or PDM. What do you think of the accuracy and helpfulness of the ICD compared to those other classification systems?
It's a really good question. I don't use the ICD, I use the DSM. So I have to base my diagnoses on DSM. But one thing I will say between the ICD and the DSM, and just kind of in general, I think psychiatrists are moving more towards a spectrum of illness across the board with all the different types of psychiatric illness. I think we think about, schizophrenia to bipolar disorder, the psychotic aspects, the manic aspects as a spectrum. We see the mood disorders in a spectrum. We see the more trauma disorders as a spectrum. And so I think that there is this shift in diagnosis. Sometimes we, as a forensic psychiatrist, we do have to use the DSM-5 to explain our point of view to social systems outside of the medical world. And the ICD falls into that same problem of there are diagnoses in the ICD, but I think, the fact that there are more spectrum disorders, I think that's the direction we are all headed. And we're going to have to look at risk of each individual in the spectrum of the disorder that they have. In order to forensically determine where they need to be.
The next question says, are you aware of the research suggesting links between racialized violence, discrimination, exacerbating events of SMI in Black-brown populations? I'm curious about the overrepresentation of Black folks and other BIPOC individuals in the psychiatric system. Also, I'm mindful that the policing and incarceration of folks of color is a contributing factor.
100%, all of that. And that's part of the reason why I got really interested in this research, because I knew that this population I was looking at was a larger minority than the population of my state. And, I was seeing all this delay to care happening there. my perspective was, wow, wouldn't it be amazing if we could just get treatment to this individual kind of as they come through our doors, so that that recovery process can happen much quicker, then they don't end up committed to a forensic hospital or end up kind of going through the cycle of jail, at forensic hospital, jail, community forensic hospital, and rather get treated upfront and then maybe have this better chance for recovery in the community. Of course, there is a social justice issue here as well, that we need to talk about. And that's why I really want to say we need to do more research on forensic populations, because that's where a lot of our minority mentally ill individuals are, because of our social justice problems in this country. And so we need to do the research there so that we can give better care and that we can get people back into the community where they can be a part of more evidence-based medicine. So, 100% that was something that was in my mind as we were doing this research project, and I hope it results in something better for this population that is more minority based.
And then we just have somebody who I guess has a question and then also a comment. So where does NAMI stand regarding the polarity of treatment be the right to object versus the right to object treatment? I think you might have touched on it a little bit in your presentation.
I did. Let me see if I can, oops. Oh, here. So I think I just wanted to reiterate this, that the NAMI's stance on this is that involuntary treatment decisions must be made in a timely manner, in a single hearing. You can't have like a commitment hearing and then a treatment hearing like we have in Massachusetts. It should be one hearing. You talk about medications. The role of the court should be limited to review, to ensure that this is all being done with due process, but not to slow down the treatment. Because what we know, and what the research that I just described to you showed, is all of those adverse events significantly decrease when we get treatment in place. We also know from the literature that recovery can happen faster and better when we get treatment in place. And so NAMI's stance is like Treatment Advocacy Center to say, like, treatment is an integral part of stabilizing someone in serious mental illness. And we need to really think about the way we provide care and not to slow it down. And unfortunately, it seems like the WHO does not have that in mind in creating its action plan.
And then their comment is that it's a very interesting presentation, but that they noticed that the pioneering California laws were not included. So maybe they're just pointing you in that direction for your own interest.
Thank you.
Are there any current cases headed towards SCOTUS that might resolve the issue of involuntary medication treatment at the national level that you're aware of?
That's a great question. So there's a lot of cases moving through around mental health care access, and actually within our state Supreme Court, we have some cases, and actually in our legislation, we have a big parity law that just was accepted about mental health care access should be equal to medical care access. I think the piece that's missing in all of this conversation around mental health care access is the fact that our laws don't actually parallel this belief that mental health care access should be available. I will sit there as a psychiatrist with mentally ill patients that I'm not allowed to treat. So even when there's a lot of access, we can't necessarily administer that access because of commitment laws and treatment laws. And like I said, certain states, every state does this differently, but no state is doing it particularly well. And we really do need to think about mental health care treatment access as our main goal in destigmatizing mental health care. And in order to do that, one piece of this conversation is treatment over objection, due to the fact that anosognosia is a symptom of some types of serious mental illness. We just have to know that that's part of it.
Then one real quick question before we go to the next question. So somebody's asking if they can use the recording in a seminar that they offer in mental health counseling in the legal system. For like today's.
Yeah, that's totally fine.
All right, and then the next question says, I'm curious how the prevalence of substance use disorders impact community-based treatment plans like you discussed. Relatedly, there's a lot of stigma blame of individuals with substance use disorders that may prevent them from accessing mental health services. What do systems need to do to provide treatment for this dual diagnosis population?
Destigmatize substance use medications and treatment too. I think that this is kind of across the board an issue. We want better mental health care access. We want better substance abuse care access, and yet we have a lot of feelings around the treatments, around psychiatric care and substance use care. We just have a lot of feelings around the medications, and that is cultural. That is global. I think that there's an internal conflict we all have with psychiatric treatment and psychiatric care. And we believe that they're psychiatric medications and psychiatric care. Unfortunately, they go hand in hand. And I think that there's sort of this, like, we want care, but we don't want medications. And that's sort of this conflict that we're all in. And I think addiction treatment falls in the same stigma as other mental illnesses.
Yeah, so I want to be really respectful of your time. So I know you have a meeting and it's right at that 5-minute mark. So thank you so much for being willing to stay on, and sorry for the few people that we weren't able to get to your questions. Thank you again for your time. It was really, really interesting. I'm sure a lot of people very much enjoyed it. So thank you again.
Absolutely. Thank you for having me. And I appreciate this opportunity to share this with you. Thank you.
Thank you. And then I think we'll stay on just for a few minutes so people can, the CU link has been posted. You're welcome to jump off, Dr. Biswas, but we're gonna just hang on so people can grab that CU link and get their credit for today.